Okay, now we're going to move to our second debate. I'd like to call up Doctors Lachelle Weeks and Lionel Ade to discuss whether there is or is not a role for anti-inflammatory treatment for MDS. Dr. Weeks will start us off with absolutely there is.
All right. Thank you, everyone, and thank you to the organizers for inviting me to speak. So I was asked to talk about a role for anti-inflammatory treatment in myelodysplastic syndrome. These are my disclosures. And so I'm going to take you back to my residency training, and I was on service with Rich Stone, and he made this comment that there are really only two reasons to ever treat a patient. One is that patients want to live longer, and the second is that patients want to feel better. And so the summary of what I will talk about today is that if a treatment has some proven efficacy in achieving either of the above goals with acceptable toxicity, then we should use it. And if a treatment has potential efficacy in achieving either of the above goals with acceptable toxicity, we should probably be studying it. So myelodysplastic syndrome is an inflammatory disease, and we know this kind of even going back to pre-myelodysplastic syndrome, to the clonal hematopoiesis state, where we have this age-related associated increase in pro-inflammatory cytokines that are circulating in the serum of patients with CH. And that doesn't go away just because they transition to MDS. In fact, it actually gets worse. So we know that inflammatory signaling in clonal hematopoiesis both drives clonal selection and expansion of myeloid cells that contain these CH mutations. And we also know that this inflammatory signaling also drives non-malignant comorbidities, which are very important for patients with lower risk entities. And when we think about inflammatory signaling in MDS, there are many different targets, mostly around this idea of stopping this myeloid skewing, stopping the selection that is occurring associated with inflammasome activation. And so targets like NLRP3, inflammasome inhibitors, anti-cytokines, anti-IL-6, TNF, or IL-1 beta, anti-TLR and anti-JAK-STAT therapies have all been sort of posited that maybe they will work in MDS. There are several systemic inflammatory disease presentations in myelodysplastic syndrome. About 10 to 30% of MDS patients, depending on which survey you're reading, will present with systemic inflammatory and autoimmune disease manifestations. We just heard about a patient who had pericarditis, likely related to their MDS. We also have the advent of VEXAS syndrome coming on the block, which we know is a separate syndrome, but also is a clonal hematopoietic disorder that's caused by myeloid-restricted mutations in UBA1, and 50% of patients with VEXAS meet criteria for myelodysplastic syndrome diagnosis. We also know that patients with MDS, about 20% of them will have PNH clones, indicating a degree of humoral or innate immune activation from loss of complement inhibition. Immunosuppressive therapies are already a part of the NCCN guidelines for treatment of lower risk MDS, as we all know. We use IST in patients for the hematologic improvement benefit when patients have hypoplastic MDS, when they're less than 60 and have low blast count, when they have STAT3 mutations, or PNH clone positivity. We also know that there's some difficulty in treating the systemic inflammatory and autoimmune disease manifestations in myelodysplastic syndrome. So the arthritis that is presenting in a patient with myelodysplastic syndrome might not respond to the same disease-modifying therapies that we typically use to treat arthritis in other rheumatologic settings. Similarly with vasculitis. And a lot of providers who treat MDS have turned to treatment with azacitidine or even stem cell transplant in order to manage the systemic inflammatory syndromes that are associated with myelodysplasia. I did with Ben Ebert a survey using SEER data where we looked at the prevalence of age-related inflammatory diseases in patients with myelodysplastic syndrome, and we saw that compared to Medicare controls without myelodysplastic syndrome, there were more prevalent cardiovascular diseases, mostly ischemic heart failure and atherosclerosis, more prevalent chronic pulmonary disease, chronic renal disease, non-alcoholic fatty liver disease, as well as inflammatory arthropathies. Cardiovascular disease has emerged as a common cause of death in patients who have pre-MDS or CCUS. And we heard earlier today about this SEER data from Andy Brunner in 2017, which indicated that cardiovascular disease is actually a very important cause of death for patients with lower risk myelodysplasia. In the clonal hematopoiesis world, the CANTOS trial really was exciting for us because it demonstrated that IL-1 beta inhibition actually can reduce the likelihood of major cardiovascular events in patients who have specifically TET2 mutated clonal hematopoiesis, and this has spurred some interest in trying canakinumab and IL-1 beta inhibition in order to prevent cardiovascular disease outcomes even in lower risk MDS. So thinking about MDS management, the path that we currently take is really sort of centered around eradication of the malignant clone, improving the hematologic state of our patients in symptomatic and high-risk disease. And so what I'm putting forward is that there probably are some other paths towards getting drugs approved in myelodysplastic syndrome, thinking about reduction of inflammation in order to improve fatigue and autoimmune manifestations of MDS, which are a major cause of morbidity, and in the situation of cardiovascular disease, a major cause of mortality. And thinking as how we design our studies, where inflammation is really one of our primary targets, thinking about a reduction of inflammation as primary and secondary prevention for cardiovascular disease events. These things would both make patients feel better, but also will have the benefit of improving the longevity for patients who are at risk for these significant cardiovascular disease events. So in summary, myelodysplasia is an inflammatory disease, and we treat inflammatory things with anti-inflammatory agents. There's the sterile low-grade age-related inflammation, or inflammaging, that drives pre-MDS development and expansion, and clonal hematopoiesis as well as MDS, the HSCs and their progeny drive systemic inflammation, which contribute to a host of inflammatory manifestations in our patients. MDS patients have these acquired autoimmune or SIAD manifestations. They have humoral immune deficiencies or aberrancies, and they have age-related inflammatory or multi-morbidity. A subset of low-risk MDS patients with symptomatic cytopenia do respond to immunosuppressive therapy. We know this. And SIAD with MDS responds to steroids, azacitidine, and anti-inflammatory agents. And we have a limited cadre of studies that have actually directly been evaluating anti-inflammatory agents in the context of MDS, and we really should study this more. Emerging data suggests a role for IL-1 beta inhibition to prevent major adverse cardiovascular disease events in clonal myeloid neoplasia, particularly pre-MDS or CCUS, but also myelodysplastic syndrome itself. And targeting inflammation in general may improve quality of life and reduce the symptom burden and longevity for patients who have severe systemic inflammatory disease manifestations. So we should absolutely use and study anti-inflammatory therapies in patients with myelodysplastic disease. Thank you.
Thank you. Dr. Ade.
Thank you very much. Well, I totally disagree. But this is my role. Just a joke. But when Moshe Mittelman sent me an email a few months ago asking me to discuss about the role of anti-inflammatory drug in MDS, I was wondering myself, did I fall asleep for 5 years? And did I miss something in the field of MDS? And I don't think so. And I will discuss with you. So I looked, well, this is my disclosure, but they are totally irrelevant because the conclusion will be that there is no drug that is approved for the anti-inflammatory drug that are approved for the treatment of low-risk MDS, high-risk MDS, MDS in general, or whatever disease related to MDS. But before that, I looked at the drug that have been approved for MDS, both by FDA and EMEA. And when you look at all those drugs, well, not a drug, oh, yes, we don't have any anti-inflammatory drug that is approved. So I was wondering, I'm probably missing something. I will look at the NCCN guidelines. They are more innovative in the US for the treatment of MDS than we are in Europe. And I look at that. And there is no anti-inflammatory drug that is recommended. Of course, immunosuppressive therapy for what we called aplastic anemia/MDS, but immunosuppressive drug is not anti-inflammatory drugs, even if they might share some similarities. So the previous speaker, Dr. Weeks, make a huge effort to demonstrate that is something that is really true, that we have in MDS, an aberrant innate immune activation and pro-inflammatory signaling within the malignant clone that might be part of the pathophysiology of the disease. And in that paper that was published in Blood in 2019 by David Salman and Alan List, well, they were concluding that these pathways, these inflammatory pathways, provide new target, paving the future of clinical trial for MDS. And in that paper, they were suggesting several ongoing trials that were ongoing at that time, and I have depicted here those trials. Some targeting TLR signaling, some targeting MSD elimination, and so on. So I will give you an update of those promising trials that were that promising in 2019. Well, the first trial, well, very few were published. All of them do add very limited efficacy. Some were not published, some trials were closed, and at the end, we don't have any phase 2 or phase 3 trial that were published for those very promising drugs at that time. There are other pathways that were also promising at that time, NLRP3 and cytokine targeting, and I will discuss that with you within the next slide. Just started with targeting inflammation by targeting NLRP3. That is quite exciting from the bench side. But what about the bedside? Well, only ibrutinib that might target NLRP3 has been evaluated with very limited results that were inconclusive and unimpressive. And all other drugs that were recently mentioned in a review are published by different colleagues in Blood in 2022. Well, all those drugs are not clinically available. We have data only from cell line and mice, and we are not treating mice for the moment. So we only have preclinical data in that setting. IRAK4. IRAK4 is the new kid on the block for MDS. You know that it is of interest because it's associated with, well, the overexpression of the IRAK4 long isoform is associated with splicing gene mutation, and it's under evaluation in MDS and in AML. And we had promising results with emavusertib that were presented by Guillermo Garcia-Manero at last EHA meeting, but only 7 patients had MDS. So it's promising, but it's still ongoing. And at that ASH meeting, the German group will present the results of the LUCAS trial, evaluating also emavusertib in low-risk MDS, 11 patients, absence of response. Okay, interesting. What about immune checkpoint inhibitors? They are very effective in melanoma, in lymphoma, you name it, but we're not treating lymphoma, I think. This is not the Lymphoma Foundation. So PD-1, PD-L1 inhibitors, CTLR4 inhibitors, and so on. As a single agent, they are very disappointing, and when combined with hypomethylating agents, well, the results were also quite unimpressive. TIM3 inhibitors. TIM-3 inhibitors, you know the story. The trial, the phase 3 trial was presented by Lionel at last EHA meeting, and the trial was negative. So TIM-3 inhibitors are not very effective, at least in high-risk MDS in that setting. Okay, we have other pathways. What about cell-entracing target? The previous speaker talked about canakinumab. That might be effective in a post-hoc analysis, sub-analysis of a trial for cardiovascular event in a subgroup with cheap TED2. Are we treating cheap? No, we are treating MDS. So what about MDS? Well, canakinumab was evaluated in a phase 2 trial in 25 low-risk MDS, heavily pretreated, limited efficacy, 17% of hematological improvement. And once again, at that ASH meeting, the German group will present the CANFIRE trial. 36 patients with low-risk MDS were treated with canakinumab. No response. No response at all. Maybe other drug. TNF, targeting TNF, this trial was conducted with very limited response also. Finally, targeting IL-6. Maybe IL-6 is a good target. And tocilizumab was evaluated, siltuximab was evaluated, tocilizumab only case reports were reported. Quite nice, but case report. And siltuximab versus best supportive care, the trial was stopped early due to the lack of efficacy. So at the end, yes, the guidelines are right. There is no indication for anti-inflammatory treatment in MDS in 2024. The pathophysiology of MDS suggests an important role of inflammation and aging, but we don't have any drug that is approved or on the path of an approval in that setting. The clinical results of clinical trial are quite disappointing for the moment, but we have very few patients. Probably we are not targeting the best population because we are treating patients with low-risk MDS. And maybe targeting inflammation when MDS is already present, it's maybe too late. So we have to make effort to think better in that setting. And there is a group that's called I4MDS, led by Sharon Kordasti from London, that is working on the immune monitoring of MDS to better understand and better select the patient who would be more a better candidate for this population. But at the end, for the moment, I think I win the debate. There will not be any poll or any voting. There is no drug that is approved, anti-inflammatory drug that is approved for the treatment of low-risk MDS. But I agree, we hope for the future to have better drugs in that setting for those patients, for patients.
All right, let's have a rebuttal.
So the great thing about these debates is that I think fundamentally all of us actually agree, which is nice. So my opponent would have us believe that the absence of approvals for drugs in MDS means that there's absolutely no role for that drug. And I am defining a role for the drug much more broadly to say that there are things that we're doing in the clinical trial setting, and there are also things that we're doing that are approved therapies for myelodysplasia. When you think about how we're designing our clinical trials for myelodysplastic syndrome, we're always looking at things such as transfusion independence or hemoglobin improvement, cytopenia improvement, and those are very important endpoints, yes, for myelodysplastic syndrome. But in a lower risk MDS population, things like quality of life, improvement of fatigue, and even prevention of non-malignant comorbid outcomes would be very important endpoints to study and to design our clinical trials around. So when we go to study canakinumab in myelodysplastic syndrome, we cannot use the same endpoints that we're using to study imetelstat or other MDS-approved therapies. We should be thinking more broadly about what actually improvement in the quality and the longevity for MDS patients who have lower risk disease actually are. And so I think that I fundamentally agree with my patient, with my opponent, that you should not go rogue and use anti-inflammatory therapies off-label for patients in MDS outside of the context of a clinical trial. But I do think that as a group, we need to fundamentally think about how we're designing our clinical trials in order to make sure that we're thinking broadly about what improvement in myelodysplasia, improvement for the quality of life and longevity for our patients actually looks like.
We do have time for questions or points from the audience, if anyone likes to comment on this. Dr. Ade, do you have a counterpoint?
No, because at the end, we fully agree.
Yes. Yes. Okay. I fear to tell you, but I have a randomized trial with curcumin, high-dose curcumin, and CICUS, but we're looking at endpoints like symptoms and VAFs in patients with these low-risk settings, states.
Yes, but CICUS is not MDS.
Right, right.
High-risk CCUS might be MDS.
Yes.
Yes, but high-risk CICUS is MDS.
That's who we're putting on trial.
Exactly.
Hi, Vita Gripka from Penn State. We heard an elegant discussion of a syndrome and all the vagaries of different presentations of that syndrome. But what is the disease? And what did these cases show us about the defining pathobiology of the disease?
So I think, myelodysplastic syndrome is really interesting to me because every patient is sort of an N of one to some extent, that the underlying pathophysiology, we can sort of drill it down to the clonality in our hematopoietic stem and progenitor cells. But beyond that, how that interacts with the patient's both intrinsic environment and extrinsic and environmental environment, I think is very different for everyone. And so what is the disease, I think, is going to be a little bit different depending on who you talk to. Myelodysplastic syndrome is largely heterogeneous.
No, I agree.
And maybe that's why we're getting so many failed clinical trials.
Exactly. So identifying the right patients is so
Maybe we
key.
need to do a better job of sub-defining this disease. Yes, sir.
I hate to be provocative, and I know nothing about MDS, but if you have a long list of drugs that have some activity and have no activity, one conclusion would be that this whole spiel of inflammatory cause of MDS may be wrong. Maybe the hypothesis should be corrected after it has been tested in clinical trial. Just to provoke.
Yeah.
I love that provocation. I do think that how we're designing the studies has not been uniform across all of those different clinical trials. They all have different eligibility criteria and different distinct endpoints. And so I don't know that we can sort of take the sort of whole of all of the anti-inflammatory trials, put them together. Failed, and so therefore there's no role for inflammation, and our hypothesis that inflammation is a driver of clonal selection and outgrowth must be incorrect. I think that we need to, as a group, and maybe with the group that you discussed at the end, come together and think about what is the experiment the in-human experiment that we actually want to do in order to definitively answer the question.
So I disagree. I don't think you should post hoc redefine the criteria. These trials are done prospectively, and the trials fail, and then you can't go back and say, well, we used the wrong criteria. A change in cytokine level doesn't benefit the patient unless there is benefit for the patient, which we can measure. So that would be my counter-argument to your argument that we are looking at the wrong endpoints here.
Can I comment? You're both right, I think. Probably if we are targeting inflammation, we are giving those drugs too late. That is probably when we are discussing about endpoint, we are also discussing about patient selection in that trial. Because if inflammation is involved, if it is involved in the pathophysiology of the disease, we should intervene quite early. The problem is giving those drugs that might be a little bit toxic. They are well tolerated in general, but to patients who do not have any disease but have inflammation, CCAS, high-risk CCAS, whatever, that might progress to MDS. And what will be the endpoint of those trials? Probably disease evolution.
Right.
It should be randomized and this is a very long-term clinical trial that will be very difficult to found at the end, because it will take years to see any differences between two arms. And but this is probably the way to go.
And I think how we're defining benefit, you made the statement that reduction of cytokine levels, it doesn't benefit the patient. If your definition of benefit is that you're modifying the clone, then that is probably not happening. We haven't seen that, right? And even in VEXA syndrome, our patients derive a clinical benefit from treating them with tocilizumab, but it's not disease modifying in that it doesn't eradicate the clone. And so does that mean that we should not treat our patients with tocilizumab and we should just treat them with steroids? No, right? There is actually a clinical benefit there. It also means that we probably should be looking for a drug that has both the clinical benefit in terms of improvement of symptoms and is disease modifying. And I don't think we've found that yet.
Okay, thank you.
And just one follow-up comment. There is a trial that didn't present it because I was supposed to say no, there is no role, but now we are discussing. And this trial was presented by the Danish group last EHA meeting, and it was a pretty straightforward trial for high-risk MDS. Patients were randomized to receive Vidasa or the combination of Vidasa and vitamin C. And this was a positive trial in terms of response, even free survival. I don't exactly remember the numbers, but at the end, the outcome was better when patients were treated with a combination of vitamin C, high-dose vitamin C, and Vidasa compared to Vidasa alone. Whether vitamin C as an anti-inflammatory, antioxidant, whatever, but there are some evidence that targeting something else that the leukemic stem cell might be effective.
Okay, I fully agree with your last statement. Thank you.
Thank you. The vitamin C study, they also had, because I work with them, in CCAS.
Yes.
And that actually showed a survival benefit.
Yes.
Survival.
Though we are investigating why. Thank you so much for this excellent discussion, both of you.